right, everybody. If you're here to talk about electronic case reporting, artificial intelligence, robots ruling the world, you're in the right spot. If the people behind stage could throw the deck up on the big screen, that would be helpful. Yeah, exactly.
We don't have a division. He's got, there we go.
Ah, there we are. All right, well, welcome everybody. If you're passing by and you're interested, stop on in. We're having a good time here. All right, well, so we're going to be talking about streamlining and automating your public health reporting. So if you're interested in that, you're in the right spot. I'm Michael Marchant. I'm the Director for Interoperability Innovation at UC Davis Health. And we've been doing this for a while, and I'm partnering with
Kathryn Bingman, Vice President of Interoperability Adoption for eHealth Exchange. And eHealth Exchange is the largest health information network in the United States. We're also a designated QHIN, and our whole purpose is to promote interoperability. And one area that we're focusing on is the public health use cases. So very excited to be here with Michael.
And I'm excited to be here as well. It's an exciting day at Vive. We're all having fun with our green lanyards and all the exciting, loud music that makes it hard for everybody to hear, but we're having fun. So wanted to just highlight again while you're here, if you're looking for information about electronic case reporting, you're in the right spot. Don't have to read the board, sir. The problem statement is that electronic case reporting essentially is being used, not to read the screen, but essentially what we're trying to do is automate and become more real-time in the ability to get information from entities out in the world that are trying to report or make case reports, and wasn't happening real time. And as we got into COVID, it became real clear and critical that that information be more real time, be more available to people, to public health agencies to respond to that public health crisis. And the process that was happening at the time in early 2020, was not something that was going to be suitable for the move forward. So the solution through electronic case reporting, at this point, there's 132 reportable diseases that are available through electronic case reporting. So if you think about this, before somebody would come into the hospital, they would have a reportable condition that would be documented in the electronic health record. Somebody might download that information, put it in a spreadsheet, upload it to public health, that would then daisy chain its way up to a federal government agency, and 30 or 45 days later, that would become actionable information. And if you think about it, the first cases of COVID probably showed up in December. My son was actually on a rugby tour in Japan where they had an outbreak in Japan in January, and it wasn't actually until March until we were taking action in the States on that. And part of that problem is the access to data and the ability to report that, and the electronic case reporting, the real-time ability, the real-time access to data in all ways and shapes and forms in this particular case has really has benefited the ability to respond to those types of crises. So I'm going to turn it over to Kathryn to talk about that process.
Right, so there's about 6 steps that have to happen to make the electronic case reports work. So the first step is there needs to be a trigger, and so there's got to be something in the provider system or the HIE system that says there's a reportable event. And again, there's a lot of reportable events. And so that trigger sometimes there's an out-of-a-box solution within the EHR that will automatically produce that electronic case report. But there's also a alternative method that can be done with a smart-on app file that has been provided by the American Association of Public Laboratories, APHL. And so they have provided a smart-on fire app called ECR Now that will allow you to launch those case reports if it's not native in the EHR.
How convenient, because we're in the Interop Now showcase. So ECR Now, Interop Now, there's a lot of correlation there, right?
Exactly. And so then the second step is there's a document payload that is included, and it leverages RCMS, which is Reportable Conditions Knowledge Management System. And that provides a comprehensive information on the case that is being reported. And so then that information, all of that information is then required to be sent to the clinical labs and to public health. And so again, there's 132 reportable events, and there's been a lot on COVID, but we're hoping to expand that and get that to be used much more prevalently. So, and then step 3. So this information flows through the eHealth Exchange hub, and we have a hub and spoke technology, and that payload goes through eHealth Exchange. We do not store any of that data on eHealth Exchange. We're the pipes. So that information goes to APHL, and APHL is a participant and has signed the same trust agreement that all of our other participants have signed, and that information is relayed to them. And then the next step is that they APHL forwards that critical information to the public health authorities that need that information. And so just like using any of the other eHealth Exchange, again, that information is not stored on eHealth Exchange but goes to APHL. So step 5 is that the AIMS platform, which stands for APHL Informatics Messaging Service, that information is then relayed back to the reporting entity so that they know that that information has been received. And they'll include important information like the travel plans that have happened, and any of the other diagnoses surrounding the patient's information. And then that information then comes back, if it's reportable in this step 5, comes back. And then step 6, that information is typically included in the medical record in the EHR. It can be, they don't have to, but it typically is stored there.
So can anybody in the audience walk us through all 6 steps? You think? you want to try? You know number 2. What was number 2, Mr. Gould? Document payload goes to somewhere magical. The AI gets it. The hub gets it. There you go. Well, luckily, see, we've prepared, and we actually have a slide that will show you all 6 steps. So if you all have your handy-dandy camera. Exactly. See, somebody wants to take a picture of that. So, there's look at all these people taking pictures. This is like a popular. Hey, ma'am, do you want to take a picture of this slide before I move it forward? No? I mean, you have a green, sir, would you take a picture of the slide? I mean, this is the perfect slide. It's a great slide. Take a picture. Use it in all your presentations. It's a wonderful thing to use. So, this is our summary process. This kind of walks you through all the important parts of what's necessary to make sure that the electronic claims reporting process is done accurately and real time. And really, that's the most important piece of making sure that you're moving in this direction as an organization and as an industry, because the ability for public health to respond in an emergency is very much hampered by inaccurate data, delays in data, and the ability for public health resources to have access to that information. So today, over 80 million, right? ECRs are sent. Okay, I thought she was going to come and bombard my slide. A month to the APL. Do you questioning that number, Mr. Gould? Impressed by that number. Anybody else think 80 million is a lot? Yeah, I got a thumbs up over here. Good, good. So again, what do you think was sent before? Yeah. Well, I mean, part of the electronic case reporting process here is to make sure that that information gets to where it's actionable. So if you're reporting 80 million conditions a month, I think if you had a sense of what is the number of reportable conditions, like what's the N, what should it be, and then what is the difference between what's being reported electronically and where should we be as an industry. And so that's really kind of an important gap. And one of the big things in the enabler here, the enabling technology, this gives you a sense right now of the volume and scale, right? So if you're familiar with the national networks, we have eHealth Exchange, we have Care Quality, and we have other exchange opportunities. This gives you a really good sense of the type of traffic that we're talking about that's handled. And if you're familiar with outside of case reporting, the national networks handle trillions of transactions a month. Document requests, document exchange, through eHealth Exchange, through Care Equality, through Commonwealth. And as we move forward with TEFCA, if you're familiar with TEFCA, the Trusted Exchange Framework and Common Agreement, those sorts of activities are going to only increase as more organizations get plugged in. Thank you for correcting my slides.
And I
go ahead.
Well,
yeah, go ahead.
Not go.
Oh, you go back. Yeah, go.
Yeah, so part of this, these exchanges happen via eHealth Exchange. So that is it goes through the hub like I described, but we have also enabled the Care Equality implementers to be able to send that via via direct messaging. And then like NextGen and Athena have been using XDR. But they're all using our trust agreement, which is called the Data Usability Reciprocal Support Agreement. And we've allowed that transmission of data to happen for free to do that for the public good.
Yes, very much so. So, public good, right? So we talked a little bit about this, got ahead of myself as my slides freaked out. Again, appreciate you stopping by and hearing our story. So data is available immediately upon collection, right? So real-time exchange. Information is documented in an encounter, whether that's the ED or an ambulatory visit or as more home health visits occur. You name it, that information becomes available, and then at that point, it allows that information to be sent to public health officials and their ability to collect that data, review that data, and then respond appropriately in real time, depending on what that is. Whether that's I think there's a recent measles outbreak. I'm not a public health expert, but I think some of you who pay attention to the news, there are ongoing public health concerns where access to data, real-time information allows for public health and for folks to respond to that and take action regardless of what that is. And this is really a solution for everybody. So the ability to plug into electronic case reporting through the networks that are available today and make sure that information is available is something that's very important. Sir, if you'd like to learn more about case reporting, feel free to stop on in. We're good? Okay, I guess not. He's not interested in case reporting, so he doesn't care about public health. It's okay, sir. And again, sorry, I'm just trying to make this entertaining. Like, you guys see people get up here and talk all day and throw stuff out. So, and again, just to bring it back around, eHealth Exchange is somebody who provides that service to anybody that's using those national networks, right? So it's not something, there's a low barrier to entry. Most EHR providers are participating in that today, and really just leveraging the network and the capability is something that you could do, again, with very low barriers. Any other comments there, Kathryn?
Yeah, I think, and this is very supportive of TEFCA and where we want to go in the future. Public good and public health is really important, and we know there could be additional pandemics. We want to be prepared, and so this is a way that we're supporting that move to TEFCA across all the QHINs, the Qualified Health Information Networks. All
right, we're going to go out of order since we're way ahead on time. You had a question, sir? Oh, you had your hand up. So yeah, go ahead. Right. So the question is that he's looking at an EMS use case. So I'm in an ambulance. I've run into a patient or have a situation where I encounter that information. Right. So EPCRs haven't traditionally been plugged into the national networks. Now, I know that that's changing, and he'll tell you about the solution that might be changing that for Alameda and for other organizations. But I think that the idea is that the technology, the network, and the availability of that connectivity is something that's real and happening today. And it's really up to vendors like ImageTrend and all the others that are out there in the world that do EPCR work, and my EPCR knowledge is somewhat limited, so I apologize. Can't name other vendors, so apologies to the other vendors who I haven't named, who may not be doing this today, but they probably don't want to be named in this recording anyway. But yes, they can plug. Yes, yeah. Beyond Lucent can talk to you if you have interest in that. So stop by. Yeah. So what's the vision for plugging in? So do you think that eHealth Exchange have a vision for plugging other organizations in?
Well, that's one of the really great things about TEFCA and the
TEFCA, Trusted Exchange Framework and Common Agreement.
Very good.
There you go.
I've got a tickle. Anyway, that's one of the great things, because we're being able to connect additional vendors and different kinds of we have these large gaps in care, And these additional QHINs we've been focused primarily on treatment. We have, 60 of the state and regional HIEs. We have 5 federal agencies, and we have 75% of all hospitals. But we're missing a big piece of the market, that post-acute market that's not part of a big hospital system, the EMS components, all of that is not in the picture. And so the nice thing about TEFCA and designating a variety of QHINs, if you look at the landscape of QHINs, we're not all alike. It's very different, and that will expand to some of those other areas. And, Node 2 has a very different kind of customer than eHealth Exchange has participants. So we're excited about that. And then, as we move towards these additional use cases, not for just treatment, but care coordination, and then the public health, that's going to encourage additional connectivity. We're hoping that we can get smaller organizations and, provide mechanisms for smaller organizations to be able to connect without the big barrier of cost, keeping them from being able to get that critical information when they need it.
Yeah, and I think that's really the promise of non-traditional actors participating in exchange, and what were their barriers and how do we remove them. As Kathryn said, most of the exchange happening today is centers around treatment, and I think as we expand those use cases and people become more comfortable with operational exchange, even though there may be clinical components, there may be operational components or public health components, research components, again, those are all things that are going to be covered through that TEFCA-based exchange. So as we get to looking at outcomes, so I know we haven't answered your question, but I think that I appreciate you engaging as a wonderful audience that you've been today. The poor 2 guys from the showcase that had to sit down because there weren't enough people in the audience. So I appreciate you being here too, sirs. So the outcome. Reduction of burden. So do we understand how we reduce burden by doing electronic case reporting, right? So instead of creating spreadsheets and processes separate from your clinical workflows, you're now actually enabling the clinical workflow to support the exchange real time, and that data leaves the technology stack that you have in place as those workflows happen, and not through or via separate processes, right? It's cost effective. When I say cost effective, is these networks are up and running. Adding case reporting, adding this use case or purpose of use to your outbound exchange network is easy to do, and it's a low barrier to entry because you're already doing it for exchange. It supports, again, the 132 reportable conditions. So again, you can look up all 132 if you're very interested. But again, I think those numbers of use cases will expand as we understand and as public health expands on those definitions, because it's all rules-based, right? Quick to implement. Again, the network's there, so the infrastructure's there, and it's reliable. The process is in place. It works. There's troubleshooting. There's a lot of different safety net and safeguards around the existing exchange. So it is really something that would be beneficial for all to implement. So Kathryn, although it says my name, I think this incentive program is for you to talk about. So, okay, Tina.
All right. Okay, so we at eHealth Exchange have created an incentive to help with additional connectivity and to expand this use case of electronic case reporting, to go not only from electronic case reporting, but to encourage electronic lab reporting and then electronic case investigation, so adding some additional components. And so we're doing an incentive, and this is for public health and HIEs, that we're waiving fees for them to be able to connect. And if they're an existing participant, we'll waive a fee for a year. If they're a new participant, public health agency or HIE will waive up to 3 years of their fees. And the important thing is to get that additional connectivity. And so, when we have sent this out, we've had a lot of interest in this so far, and so people have to commit that they say, hey, we're going to do this by the end of April, and then by the end of June they need to start testing, and then by the end of the year they need to start exchanging in production, and then need to get the next year's incentive and the year incentive after that. They still need to be exchanging data for public health purposes. And then we're also entertaining any other ideas other than electronic case reporting, lab reporting, or the case investigation. And we're entertaining fire as a way of exchanging. We have a large project that is live with the FDA for adverse events post-immunization, and that's where the data is being exchanged using fire, and we're using 16 fire resources and did a quality analysis with the FDA on that, and the quality of the data was very good. So we're using that same technology and expanding that into some of these new use cases. So get the word out if people are interested. We are doing this for the public good. We're a small not-for-profit, so we're really just trying to promote interoperability.
Yeah. So, and as you see, the slide has a QR code. If you're unfamiliar with that process, you take your little phone, you point your camera at the QR code, and a little link will pop up, and then you can get the information about the program. So I think, Kathryn, we have one more thing here.
Yeah, and you probably know about TEFCA, the Trusted Exchange Framework and Common Agreement, and we are a designated QHIN and are excited about the partners that we've been working with. We are exchanging PHI with other QHINs today and are very excited about expanding that. And I just wanted to make a comment that the work we've done with the other QHINs has been extremely collaborative. And so we're doing some joint joint testing, everything else has been very, very cooperative. So it's been a great experience.
Yeah, and so if you're unfamiliar with the different QHINs or the process, it has been a very rigorous process for eHealth Exchange and for the other vendors that are participating. But again, the idea today is that about 70% of organizations participate in Exchange through TEFCA, support of other purposes of use. New organizations can join and exchange and participate as we move those things forward. So, what we want to do is just make sure people are aware of that, understanding and supporting that, and electronic case reporting is just one leg of the stool of healthcare interoperability. So, thank you very much. Yes, exactly. So we are now in for questions. Do we have any questions about electronic case reporting? Yes, sir. He's got 2 questions. Okay. How is case reporting different than any other EHR exchange? Okay. Right. So the second one is marketing. How do we make sure that everybody in the healthcare market space that could take advantage of eHealth reporting, e-case reporting, I'm waving to I was fanboying your podcast recently, yes. Sorry. So how do we get the word out to let people know that that capability is available to them? And I think, again, eHealth Exchange is doing a wonderful job marketing that. You have a comment too, Kathryn? Yeah.
Well, and I think that's one of the other good pieces about having this national exchange promoted by the Health and Human Services, because it is getting more attention, and then more will be able to understand it. And it's really up to a lot of the vendors to make sure that this data is ingested in their workflow, and so that people are aware of it. And for your first question on how this is different, this is a push of data. So we're pushing electronic case reports to APHL rather than typically with treatment, with some notable exceptions with treatment, people query for the information. Kathryn Bingman is in Colorado, so I'm going to look at 5 different major organizations in Colorado, and I'm going to query for results there. This is pushing out that information instead. Yeah, very, very different workflow.
Yeah. Right, and the process for reporting is that the system that you're working in understands where to send that information and how to send that information, and that's part of the onboarding process for case reporting. So, any other questions? eHealth Exchange, how long has eHealth Exchange been around? How long has case reporting been live?
Well, I know we started really pushing during COVID, but it was available before that. But I don't think there was a lot of adoption, and we really made a major push.
So let's pretend it was 2019. We'll make it up, okay? Well, now you have. So be an evangelist.
Exactly.
Case reporting. Any other questions from our thank you, sir, for coming. Really appreciate it. Enjoy the rest of your show. Sorry, I like to break down the third wall. It's just you just can't sit up here and just talk at you. So we're all in this together. I appreciate you being here. If there's no other questions, we'll wrap it up. And again, thank you, Kathryn, for the invitation. Thank you, eHealth Exchange. Thank you, Vive.
Thanks.
Thank you, Los Angeles.
Thank you, Michael.
Thank you.